This is a symposium by CORDIS, so thank you for that. And the session is going to be organized as follows. So I will try to summarize some ideas regarding this important study, the SELUTION DeNovo. Then David Smith will present a case and also present his ideas on that. And then we got the panel, which is Alexandra Lansky from the US, and then Thomas Risanen and Mauro Guito from Europe. So having said that, I will go to discuss in 7 minutes the one-year results of the SELUTION DeNovo trial. This was presented in TCT by Christian Spalding. You can see here the PIs. I was invited to comment on this study despite being part of the study. I disclosed that to the TCT organizers, and they were happy with that, so I was happy also with that. And I will try to be as critical as possible. So regarding the value of DCB in de novo lesions, there were, and I discussed that in my previous talk, there were plenty of small but empowered randomized clinical trials suggesting that DCB are equal clinically as drug-eluting stents. We performed this early meta-analysis proving that, but then cage-free was unable to meet the non-inferiority endpoint, and there was this interaction with vessel size that we have discussed. Then there was additional meta-analysis by Bernardo Cortese in small vessels and by Robert Byrne, also putting together all the information. And again, the results were that DCB regarding clinical outcomes are similar to this. However, clinical practice guidelines do not yet recommend DCB for de novo lesions, and this is where we are before this trial. So paclitaxel is being classically preferred for DCB because it's a lipophilic agent. This is clear. And we perform, and this we'll discuss tomorrow, a randomized, a meta-analysis comparing randomized clinical trials, comparing paclitaxel with early generation Limus drug-eluting stents. And it was very clear in this study that late angiographic findings are superior with paclitaxel as compared with prior generation Limus tests. So this is a new sirolimus DCB. And just before the presentation, 2 papers from the group of Reno Birmani showing data in animals demonstrated that this balloon is in fact able to reduce new intimal hyperplasia, and also that the drug is maintained in the vessel wall in a similar way to the drug after, let's say, a conventional drug-eluting stent. And there was no issue regarding distal embolization. So this is the technology, microreservoirs with a proprietary phospholipid coating. And my summary of this important trial is that this is the largest ever study on DCB. More than 3,000 patients, more than 60 sites. The study was conducted in 3 years, and the study was powered for clinical endpoint, target vessel failure, with a power of 90% for non-inferiority at 1 year, and also with a nice power for non-inferiority and perhaps superiority at 5 years. Importantly, the study examined a treatment strategy so that the use of this sirolimus balloon with provisional drug-eluting stent implantation was not considered a crossover, and the criteria were the classical criteria we've been discussing today. And importantly, there was no limitation whatsoever regarding vessel size. Another important issue, randomization was performed before lesion preparation. There was a predefined flexible non-inferiority margin that was stated in the design paper published before. The primary endpoint was non-inferiority regarding clinical endpoint, target vessel failure, using the intention to treat strategy in the full analysis set. And as most studies in interventional cardiology is open, but there was an independent clinical event committee, the DAVT Safety Monitor Board, and there was also independent angiographic core lab and statistical analysis. So these are the results. The absolute risk difference in target vessel failure at 1 year was less than 1%. And you know, the upper bound of the confidence interval was below the non-inferiority margin, so non-inferiority was met. Important to keep in mind that provisional stenting in the DCB arm was needed in 21% of patients, that there were many patients with multi-vessel disease. The proximal LAD, which is, you know, always a worrisome scenario, was treated in 20% of the lesion. In 2/3 of the cases, the device, stent or balloon, was larger or equal than 3 millimeters in diameter. And there was also, of interest, no interaction in vessel size. So this is again the primary endpoint as presented in TCT. Non-inferiority was met. This is the presentation in Kaplan-Meier analysis. And this is the components of the primary endpoint, rather similar, but you can notice that the clinically driven target vessel revascularization was higher after the sirolimus coating balloon strategy. And this is the pre-specified subgroup analysis. And there was a formal interaction that was noticed in according to SES. So this drug coating balloon performed better in male, and this was surprising considering the vessel size, in high bleeding risk patients, and also surprisingly in patients with calcified lesions. So there is need to explain that. So some issues. This is all-comers like inclusive design because there were some exclusions, left main, CTOs, ISR, and unstable patients with non-STEMI, hemodynamically unstable. In addition, all lesions were considered suitable for either sirolimus-eluting balloon or drug-eluting stents. But the operator should perceive the probability of provisional drug-eluting stent implantation per patient less than 30%. This suggests that really complex lesions were probably excluded. There are very few mechanistic insights. There is no QCA data yet. So there is no late angiographic follow-up required. So we have no data regarding binary restenosis rate, late minimal lumen diameter, percent diameter stenosis, or potential late lumen enlargement, which is of interest in the limus DCBs. And there was no requirement for intracoronary imaging. Again, no mechanistic insight in this regard. Now, there was a low use of special balloons before the sirolimus-eluting balloon, so per treatment perhaps could have been improved. And there was a low use of intracoronary imaging in both arms, 17%. And we've been discussing today that if in the drug-eluting stent arm, intracoronary imaging is now a 1A indication in complex lesions, so perhaps the stent arm could have done better. And there was a higher target vessel revascularization in the sirolimus-eluting balloon arm. Whether this probably a statistical significant difference according to, let's say, conventional standard has clinical implications remains unclear. The per protocol are not still provided, and per protocol results are very important in non-inferiority trials. And the special benefit for sirolimus-eluting balloon in male and high bleeding risk patients and calcified lesions perhaps are difficult to understand, and should remain now as hypothesis generated. So my conclusions will be that in de novo lesions, this sirolimus-eluting balloon is non-inferior to drug-eluting stents, current generation drug-eluting stents regarding target vessel failure. This is applicable to most lesions and most vessels we see in everyday clinical practice. The study emphasized the importance of a pragmatic treatment strategy for DCBs. It is important also to keep in mind that there is no class effect in this technology, and it's quite clear that this information is not only of value to inform clinical practice, but should be probably used to inform next clinical practice guidelines. So with this background, I think David is going to present a case which will be provocative for sure, and then we will have a discussion with all the panelists.